or hypertensive. When I say high BP, when the BP is more than 140/90, measured in 2 occasions with 4 hours apart, and diastolic blood pressure is taken in case of a Korotkov sound 5. So this is a very direct question. So when you say high BP, when the BP is more than 140/100, which is measured around 2 occasions, 4 hours apart with a diastolic blood pressure. Now, coming to the topic proper, hypertensive disorders in pregnancy. What is the incidence? It's very important to know the incidence. This can also be a question. Incidence is around 10%. And the preeclampsia has contributed to nearly 7% of maternal death. So again, this can be a very potential question. So all this can be asked as a direct questions. Next, we will go to the types of hypertensives. Right, coming to the types, classification, see there are a lot of classifications, ISHB, ACOG, RCOG criteria, NICE criteria. There are a lot of criteria that has been given, but we will follow the Williams 26th edition recent, that is ACOG 2020 classification. So according to which it is divided into gestational hypertension, preeclampsia syndrome. Third one is the chronic hypertension, and the fourth one is the preeclampsia superimposed on chronic hypertension. So we will be starting out one by one. So we'll start with the gestational hypertension. And I say gestational hypertension, a woman who was previously normotensive, and now when you measured her BP was more than 140/90, and it is more than 20 weeks of pregnancy, there is no proteinuria, there is no end organ damage. Very importantly, the BP becomes normal by 12 weeks of postpartum. So this is what is gestational hypertension. As I already told, there is a lot of changes. The one such change is preeclampsia is labeled as preeclampsia syndrome. When I say preeclampsia syndrome, this is a pregnancy specific syndrome that will affect each and every organ. So under this, when I say preeclampsia, you have the same components of gestational hypertension. What else is making it different from a gestational hypertension? Remember P for P, that is proteinuria, and also end organ damage. So coming to proteinuria, when I say proteinuria, when you say proteinuria, see there are three things that have been mentioned. One is if there is more than 300 milligram in 24-hour urine sample, or if you're doing a urine PCR, that is urine protein creatinine ratio, if it is more than or equal to 0.3, or if there is only a dipstick that is available as in a PHCs, dipstick which shows 1+, which correlates with a proteinuria of 0.3 gram per deciliter. So this is what is proteinuria. Or if either one of the criteria, okay? Remember, not all patients of preeclampsia should present with proteinuria. Remember, another 10% can present with severe preeclampsia without a proteinuria. Without overt proteinuria, they can present, but still, if they present with the other end organ damages, we have to label them as preeclampsia based on their severity. What are the other things? Next is the what are the other criteria that is considered is thrombocytopenia, where the platelet is less than 1 lakh, renal insufficiency, where the creatinine level is more than 1.1, or the doubling of the baseline, and there is increase in the serum transaminase level, that is liver enzymes get elevated, that is twice the normal levels. They might present with headache, blurring of vision, or even with convulsions. And then the last one is the pulmonary edema. All these are the imminent symptoms. Sorry. What do you mean by preeclampsia superimposed on chronic hypertension? Remember, if there is a new onset, sorry, remember if there is new onset or a worsening of hypertension, or if there is a new onset proteinuria, or if there is a new onset end organ damage, you label it as preeclampsia that is superimposed on the chronic hypertension. So before that, what is chronic hypertension? So when I say chronic hypertension, it is chronically present. So they will already have a history of hypertension, and the BP here, it can be more than 140/90. Remember, very important criteria, it is less than 20 weeks. Another important factor is that the BP will definitely not return to normal after the 12 weeks of pregnancy. That is one thing. When I say superimposed, preeclampsia superimposed on chronic hypertension, as already I told, there is hypertension. The hypertension may become, there is worsening of hypertension, or there may be new onset proteinuria, or there is new onset end organ damage. How is it different from preeclampsia? Remember, this one will develop earlier, and it is a very more severe form. It is often associated with the FGR. That is how you differentiate between preeclampsia. There is another, this one, delta hypertension. This can also be a question where the mean arterial pressure suddenly increases. But remember, it will be still lie in the normal range. This is somewhat may signify the preeclampsia. So this can also be a question, delta. It's a direct question, it can be asked. Next, the preeclampsia itself, previously it was classified as mild and severe. The new edition says that there is a mild, there should be something called moderate. People could not define what is moderate. So they have reclassified, and now preeclampsia is labeled as non-severe and severe type. So severe type, as we know, BP, which is more than or equal to 160/110, with all the imminent symptoms like headache, visual disturbances, upper abdominal pain presenting as epigastric pain, decreased urine output as oliguria, convulsions, and the laboratory findings saying the creatinine levels are elevated, and the thrombocytopenia where there is less than 1 lakh, and there is liver enzymes which increased by 2 times. Like there can be fetal growth restriction, and it can also lead to pulmonary edema. Okay, now whatever we have read, we will revise it. So when I say pregnancy, 20 weeks, she deliver. So hypertension that develops after 20 weeks continues and becomes normal by 12 weeks postpartum. This is gestational hypertension. If the same thing, if the hypertension develops from 20 weeks, continues, again becomes normal by 12 weeks. Additionally, during this course, they might present with proteinuria as well as end organ damage. When I say chronic hypertension which will start from the pre-pregnancy state and continues in the pregnancy, and it will never return to normal. And this is called the chronic hypertension. This is a very simple pictorial thing to remember. Next, coming to the risk factors. For any condition, you should know the risk factors. How do you remember the risk factors? Remember nulliparity. Maternal conditions. My mother, if she is a nulliparous woman, age of more than 35, and if they are very obese category of BMI of 30. These are the maternal characteristics that act as a risk factors. What else can be the other risk factors? All the chronic conditions, chronic hypertension, chronic kidney disease, systemic lupus erythematosus, or if it is an antiphospholipid antibody if it is present. Other things based on the type of delivery, that is type of conception. Remember, it is the ARTs, multiple gestations. Another condition, that is the diabetes, is also very much high risk for the development of preeclampsia, where there is also involvement of the placental vessels. So eventually, their diabetic mothers will have an increased chance of developing preeclampsia also. What are the other things? If there is a prior history of abruption or previous history of preeclampsia in her previous pregnancy or prior stillbirth, all these are the other causes for the risk factors. So what else? Other than this, there are some other new things has been added. One more thing is on the race. See, black women increased risk, and the type of any hypertension will be more severe in this case, and male fetus. Another one is HIV positive, also have an increased risk factors. If a family member, for example, sisters, your elder sister had preeclampsia, the chance of the younger sister also developing has also been implicated, somewhat like a genetic action. What is this mirror syndrome? When I say mirror syndrome, the mother will mirror the fetus. That is, a fetus will have hydrops, mother will develop edema. So the mother will start mirroring like a fetus. That is hydropic baby, where there is full, everywhere there is water filled, intra-abdominally, in the scalp, intracranial. So there is everywhere water filled. Similarly, the mother also will have the increased chance where she'll develop anasarca. There is generalized edema, which will reflect. So mother will be reflecting like that of a fetus. That is called a mirror syndrome. So this can also be a question. Now coming to a very, very important part of today is the pathogens of preeclampsia. There is a lot of questions that have been asked in the very recent NEET exam. See, the pathogenesis, as we have studied in our MBBS, that is the trophoblastic, there is abnormal trophoblastic invasion. Now we will go a little more ahead, little more advanced to understand the pathogenesis, because there are a lot of new things added in this pathogenesis. So definitely there will be a question from this pathogenesis. So this is a normal placenta. We take this part as the normal. The anchoring villi, the outside is lined by the syncytial trophoblast. On the inside is by the cytotrophoblast. Just give me a second. Okay. So we have the syncytial trophoblast and the cytotrophoblast. This is the normal placenta. So what is going to invade? Invading thing is called the extravillous trophoblast. That is nothing but the cytotrophoblast. This is going to invade the spiral arterioles. So spiral arterioles are the one which supplies the decidua basalis. That is a layer of the uterus on which the placenta is sitting. So this cytotrophoblast will start invading the decidua basalis, that is invading the spiral arteriole that is supplying the decidua basalis. It occurs as two stages. Remember, the first one is 12 weeks. It occurs as two stages in the sense the decidua basalis is the first one. First hit is this, where the cytotrophoblast will start invading up to the decidua basalis. The second one is up to the superficial layer of the myometrium. So the first hit is completed by 12 weeks and the second hit by 16 weeks. So what is this happening? This is called the vascular remodeling. When I say vascular remodeling, what happens? The vascular layer. So the spiral arterioles, the outside endothelial layer. The endothelial layer is replaced by the cytotrophoblast. And the inside muscular layer, they undergo a fibridoid necrosis. So thereby what happens? This whole process will cause converting the spiral arterioles into a large tortuous vessel. So why is this? Thereby, when it becomes a large tortuous, there is increased blood flow to the baby, decrease in the resistance to the blood flow. When the same thing is abnormal, so when this invasion is abnormal, that will lead to the development of preeclampsia. So we'll go slowly one by one. So what happens in case of a preeclampsia? Remember, it is divided as stage 1 and stage 2. Stage 1 is nothing but where there is placental pathology leading to a maternal syndrome. So when I said a placental syndrome, what is this placental syndrome? There is incomplete trophoblastic invasion of the spiral arterioles. So what happens? Vascular remodeling is defective in this. When vascular remodeling is defective, spiral arterioles will remain narrow. That will lead to placental ischemia. This will lead, when there is ischemia, there is a release of the inflammatory mediators. That's lead to a endothelial damage. Remember, endothelial damage is the culprit for whole of the pathogenesis. So there is endothelial damage not only in the placenta, each and every organ. So that will eventually lead to the maternal syndrome. What are the different organs that is involved? What are the other placental disorder syndrome? Under that, you have another 2 more things that has been mentioned. After that, we'll go to the maternal syndrome. When I say immunological factors, there are proposed that some immunological factors has also been a cause for the development of this placental syndrome. Or there is defective placenta. What happens? Normal pregnancy, there is a immune tolerance to the placenta, the paternal derived placenta as well as the fetal antigen. But in preeclampsia, or there is a loss of this tolerance. So there are certain examples they have given. One in case of a mole, that is molar pregnancy, where there is increased paternal antigenic load. So there you have, again, there is an increased risk of preeclampsia. That's why there is increased risk of preeclampsia in a molar pregnancy. Similarly, a woman is carrying a trisomy 13 baby at 30 to 40% chance of developing a preeclampsia. And there's a one more immunological factor, that is there is decreased amount of the HLA-G. So these are the 3 things that has been explained. And one more thing is TH1 as increases. So what happens normally when you have to understand the normal thing? When I say TH2 increases in normal pregnancy, that is a cell, the humoral immunity is increased in case of a TH2, and TH1 is a cytokine or the inflammatory mediator production occurs if there is increased. So, so these are the 4 mechanisms or certain examples that has been given for an immunological factor is also a cause for a development of placental syndrome. They have told there is also a genetical impact is there or a cause for this preeclampsia. That is, one is a multifactorial. Remember, it is a multifactorial. They have not specifically told what are the genetic things. Now we have understood that it is the endothelial damage that is the main culprit. Now we will understand what the maternal syndrome. When I say endothelial damage has led to a maternal syndrome, the first thing is you have to remember is there is endothelial cell activation. This endothelial cell activation again leading to ischemia, release of leukocytes, mainly tumor necrosing factors and interleukins, leading to oxidative stress. There is formation of free radicals. Again, this free radicals will cause the endothelial damage. It's like a vicious cycle. Next is atherosclerosis. Next is atherosis formation. What is atherosis formation? Remember, there is lipid-laden macrophages, home cells. And there is also activation of the microvascular coagulation. When the coagulation increases, so there is increase in the capillary permeability. So when the capillary permeability increases, there is increased chance of edema as well as proteinuria. And there is also coagulation, there is thrombocytopenia. So these are the two things you can see. So placental endothelial damage is leading to a sequence of things that is happening. Next, what are the three things we will see here is the vasospasm and ischemia. Since there is the blood vessels are not become very tortuous, now it is constricted, it's vasoconstricted. So there is vasospasm and ischemia. It can lead to obvious thing is hypertension. That's what we are seeing. What else it can lead to? Retinal ischemia that can even lead to retinal detachment. So it is important to see if a patient with severe hypertension to do a fundus examination to rule out this retinal detachment. They might present with retinal detachment, definitely they'll present with blindness, but we can't wait till the patient goes blind. You have to evaluate if there is an end organ involvement. So when you find a patient is in severe preeclampsia, it is our duty to find out that other organs are affected or not. So it is important you do a fundus. Next will be the hepatic necrosis. See, hepatic, because there is decreased blood flow, there is necrosis. The necrosis has led to increase in liver enzymes. So now you will be able to understand why there is there is thrombocytopenia, increase in enzyme levels. So everything will come under this pathophysiology. Remember, there is increase in the liver enzymes, which in turn leads to increase in the AST, that is AST-ALT, which should be 2 times the normal. Another very important thing is there can also be periportal hemorrhages. So you can see in this picture, there is a periportal hemorrhages. So when I say periportal hemorrhage, and the hemorrhage will start collecting. So there is a stretching of this capsule of the liver. So that can lead to stretching of that will lead to epigastric pain. So now you would have understood why there is a increased liver enzymes and why there is epigastric pain. Rarely, remember, rarely there can also be hepatic rupture. And this is a fatal condition. Next is our capillary leak syndrome. As I said, there is continuously endothelial damage. So the capillary becomes very leaky. So what happens when the capillary becomes leaky? Normally, first, what we see in normal pregnancy, there is hemodilution. Why there is a hemodilution? It's mainly to combat the PPH or the blood loss that occurs after delivery. So there is hemodilution. Whereas in case of preeclampsia, what happens? There is hemoconcentration. Why? There is capillary is leaky. So all the fluid goes out. So there is hemoconcentration. Remember, the hallmark of this preeclampsia is hemoconcentration. Since again it is leaky, there is a shifting of fluid from the intravascular to the interstitial space that will lead to edema. See, edema can also be seen in normal pregnancy. But how is it different in preeclampsia? In preeclampsia, you can even see there is extending up to the knees, or even it can be anasarca, that is involving the whole body. Next, again, it is proteinuria. Since it is leaky, all the proteins are leaking from the vessels. So there is proteinuria. Same mechanism. where there is shifting of fluid from the intravascular space to the interstitium. So increased chance for the development of pulmonary edema. The same mechanism again you apply it in the brain where they can develop a cerebral edema. So by this you would have understood why there is all the presentations. Another very important question that can be asked is what are the changes that you see in a kidney in case of a preeclampsia. Remember this side is a normal and this one is in case of a preeclampsia. Remember this is the fenestrations that you see on the glomeruli. So this is a glomerulus where you can see there is a fenestrations that is wide enough. But in case of in case of a preeclampsia, what happens? There is a swollen fenestra. When I say swollen fenestra, that is characterized by the formation of glomerular endotheliosis. And I said there is decreased blood flow. So there is decreased renal blood flow, and also there is decreased urine output, and there is endotheliosis. So the glomeruli is not functioning properly. So there is decreased absorption of creatinine. So there is, decreased absorption of the excretion of creatinine. So there is increased retention. So there is increase in the creatinine levels. The same mechanism does that where you can see there is increased accumulation of uric acid. So this is about the involvement of glomeruli. This is a very important question. What is the hallmark lesion that is seen in a renal in case of preeclampsia, that is glomerular endotheliosis. Next is the thrombotic sequel. When I say thrombotic sequel, what are the thrombotic sequels? See, placental thrombosis. The thrombosis can extend in from the placenta. So it can go into the umbilical cord. So there is again decreased blood flow. So they can present with IUGR. If the thrombosis is extending and the thrombosis might cause early separation of the placenta, that is leading to placental abruption. If the abruption is a very concealed kind of abruption, this will lead to DIC, disseminated intravascular coagulation. So these are the very important sequels you have to see. When I say cardiovascular, what are the cardiovascular changes? Remember, there is increased cardiac output as well as increase in the peripheral vascular resistance. The flow is also high, as well as the resistance through for the flow is also high. This will lead to hemolysis of the blood. That's why you see the feature of hemolysis. And if I say cardiac output is low, obviously the workload on the heart is high. So it is important to do an echo for the changes in the heart. Now coming to what are the hematological changes that you can see. Already we know there is hemolysis, there is thrombocytopenia, and there are very simple minute coagulation factor changes. So what is the thrombocytopenia? Here remember, platelet is less than 1 lakh. This is going to tell you the severity of this disease. So when you say it is 1 lakh, it is going to be a severe disease. And remember, after delivery, the platelet will further fall and returns to normal only after 3 to 5 days. This is a very important thing to remember. So after delivery, if the patient, if you're serially monitoring even after delivery and you see her platelets are falling, it doesn't mean you're going to give a platelet transfusion. You have to wait up to 3 days, at least 72 hours. Then you can plan for a, if it is very low or if they present with excessive bleeding, think of a platelet transfusion. When I say hemolysis, here it is microangiopathic hemolysis. Why it is microangiopathic? You have a very constricted vessel, through that a very increased velocity with high resistance. The blood has to flow, leading to microangiopathic hemolysis, which is characterized by increase in the lactose dehydrogenase, decrease in the haptoglobulin, and the peripheral smear will show a hemolysis picture like the presence of ascidocytes or spirocytes, and obviously you will also see a reticulocytosis. What are the coagulation changes? When I say coagulation changes, remember there is increase in the factor 8 consumption. What are the other things increases? Another one is D-dimer. Remember what remains unchanged. It is very important. Prothrombin time, APTT. Don't do all these things in case of a, unless you suspect a DIC, there's no need to do a PTA, PGT or fibrinogen level. What are the things that decreases? Here it is nothing but the antithrombin level, as well as protein C and protein S. So this is about the hematological changes. Now coming to the increased pressure. See, normally what happens in the pregnancy, this increase in tortuous vessel will cause a decreased reactivity to a pressure agent like an angiotensin 2 or norepinephrine. But here what happens in preeclampsia, the vessel is very small, narrow. Still there will be a increased reactivity to this pressure agents. So that is very important. Pathogenesis. Another one is prostaglandins. Prostaglandins are synthesized by the arachidonic acid. Then it is converted into three things, that is PGI2, PGE2, as well as the thromboxane A2. What happens in preeclampsia? Remember, this one is a vasodilator. Obviously, what happens? The PGE2 decreases. So there is decrease in PGI2, as well as decrease in the vascular endothelial growth factors, as well as decrease in the nitric oxide, which is also vasodilator. Another important thing, there is increase in thromboxane A2. PGI2 is to thromboxane A2 ratio decreases. Remember, this was a very recent question in the NEET. Recent question. So this you have to remember. What else is important is presence of endothelin. See, endothelin is a potent vasoconstrictor. Is a potent vasoconstrictor. So in preeclampsia, there is increase in this endothelin levels. And remember, endothelin levels are decreased by magnesium sulfate. That's why it is very useful in prevention of eclampsia. Very new and very upcoming that is seen as the angiogenic and angiogenic factors. Remember, there is imbalance in this, imbalance of this angiogenic and anti-angiogenic factors. So that is leading to the development of this preeclampsia. Remember, what are the anti-angiogenic factors? That is very important. There are a lot of anti-angiogenic things, angiogenic things, but we will remember only two things that is very important from the exam point of view. One is the soluble FLT1. So this is, remember, this is a soluble variant of this VEGF, that's vascular endothelial growth factor. What happens in preeclampsia? There is increase in the soluble FMS like tyrosine kinase 1, this anti-angiogenic factor. What happens? This increased, it mimics like a VEGF. It goes and sits in the receptor of the VEGF. Okay, go and binds to the receptor domain of VEGF as well as the platelet growth factor, thereby decreasing their free levels of VEGF as well as the platelet growth factor, leading to endothelial cell dysfunction. So this is a very important thing, and this can be asked as a question. Another very important thing is the soluble endoglin. Soluble endoglin is the second one. Remember, it inhibits the transforming growth factor beta that is present in the endothelial cells. Thereby, what happens? There is decrease in the nitric oxide levels, thereby leading to vasoconstriction. What are the upcoming things that has been using this angiogenesis and anti-angiogenic angiogenesis? Is one is there is increase in the level of SFLT, one, and decrease in the platelet derived growth factor. They correlate with the preeclampsia. And the next one is doubling of the soluble FLT as well as soluble endoglin has been proposed. And similarly, when I say doubling, this too will be directly proportional to the preeclampsia. If that is increasing, that is that the severity of the preeclampsia is also high. So this are being under trial for the usage as a predictor of a preeclampsia. When I say predictor, see, there are a lot of predictors that has been advised, but till today there are no thing that has been followed, or there is no predictors as such. As I have already told, that is SFLT, PLGF. These are the things that has been used. And one more thing routinely done, though these two things are not routinely done, one routinely done is the uterine artery Doppler, which can predict. Remember, uterine artery Doppler, there is diastolic notch remains beyond 24 weeks. There is an increased risk of preeclampsia. This is only one thing that is done, but still it is not advocated by any of your guidelines to do this or that. There are a lot of trials going on. Still, it has to be proposed, which has to be done. So if they ask what is the predictors that is available in markets, remember, no other predictors still approved for its usage. How do you prevent it? Prevention, there are a lot of things advised, but remember, one thing that has been proven is aspirin, which you give it at a low dose, 50 to 100 milligram daily. Another one is a calcium. Another very new thing that has come up is the metformin. Statins. See, they found that these two have a very high, good effect in preventing the preeclampsia, but still under trial. But please remember, this has been added in the 26th edition. So this might be a question. Other two things that can be used for prevention, one is in metformin, especially in case of a diabetes and pregnancy. That's what they give. And statins, actually it is contraindicated in pregnancy, but still they have under trial for its usage for prevention. Next, what are the things that says that you can prevent? Remember, they say the salt restricted diet. Salt restriction diet is absolutely not advised. Another one is fish oil tablets helps in prevention. Again, that is proved to be wrong. Another one is exercise. To some extent it is, but not fully proven. Another one is using of low molecular weight heparin. Again, that is also not proven much. Next, coming to the diagnosis. So now we have seen the pathogenesis. Now we'll come back to a diagnosis. When I say diagnosis, a patient coming to you, how will you start? We start with the examination of the patient, start with your BP. So there are certain recommendations that is given. Remember, this is also can be a question that can be asked. What are the recommendations for the measurement of blood pressure? One is, remember, it should be done in a sitting position. and not in a supine or left lateral position, and the cuff size should be 1.5 times that of the circumference of the arm. This is a very important question that can be asked. And diastolic, as already I've told, it is at the cohort of 5, phase 5, and we are using a calibrated aneroid device or an automated blood pressure. See, previously this automated blood pressure machine was not advised, but now recently it has been validated. So there is you can also use for measuring the BP, that is automatic machines are also used. Next, once you have measured, now you know what are the BP, this one. Now we'll start with, now the her BP has come as 140 by 90. How will you proceed? See, this is, I have gone like, how can you approach a clinical scenario based question? So that's how I'm going to explain you. Remember, when the patient has become, you have found that her BP was 140 by 90. Remember, as the definition says, you measure her 2 times 4 hours apart. There, she might be anxious about, or she would have just arrived and you would have checked her BP, it would have been high BP. So remember, always you check a patient's BP 2 times 4 hours apart. Again, her BP was 140 by 90. Once you know, now she has come under hypertensive. Now we have to know what type of hypertension, whether she's gestational or preeclampsia. How do you differentiate? So you'll start doing her urine protein. If you're in your OPD available for dipstick, you do immediately dipstick, or you send her the urine PCR. And based on that, if she have a proteinuria, then you will label her as preeclampsia. Remember, not all of them should have proteinuria. Instead of that, she might give it other things. So now once we have labeled her as preeclampsia, now we assess her severity. Severity is assessed by if she gives imminent symptoms like headache, blurring of vision, nausea, vomiting, epigastric pain, if she gives a decreased urine output and breathlessness. All these things you will assess the severity. Once you assess the severity, simultaneously you will start sending investigations to rule out her end organ damage. See, very importantly, you do a hemogram. Hemogram, I told you can see the hemolysis. Remember, you have to send it with the peripheral smear always. You will see also send for the hematocrit, very important. You will see for the hemoglobin, hematocrit, the platelet, all this you will see in a case of a hemogram with a peripheral smear. LFT, you will see where there is increase in the AST, ALT 2 times, and there is in case of a KFT where there is increase in the serum creatinine levels, and it can also be serum uric acid levels. What else? Other things you can do. One, you can do the fundus in case, or you can also do GECO. And in case of a chronic hypertension, remember we have to do a renal artery Doppler, which is a must in case of a pregnancy. You do a renal artery Doppler. Once we have seen all about mother, we can't be sitting with the mother. It is also important we see for the fetus. Fetus, you will say, ask her for a baby movement. How is a baby movement? We'll take the patient to do an ultrasound. Your ultrasound, you will see for the biometry, the Doppler, the Leica. Remember, you have to do twice weekly. That is, after 30 weeks, we can do the 32 weeks, you can do biophysical, but from 30 weeks, you can start doing biophysical profile. And the biometry is very important, as well as the Leica is very important. You keep on doing every twice weekly. Once you see it is a severe preeclampsia. Next, coming to, once you have found she's hypertensive, you have seen it's a severe now you have taught it is a non-severe preeclampsia. Okay, non-severe preeclampsia, or it fits severe preeclampsia. You have to start her on antihypertensives. So when do you start her antihypertensives? When the BP, see, book says it is 160 by 110. Remember, you wait till that she would have thrown shishas. Normally, when we ask you what is the BP, remember 150 by 100 can be the first answer. If this answer is not there, then the answer will be, the second option will be more than or equal to 160 by 110. So that is when you start your hypertensive. What are the antihypertensives that is available? And the most commonly used drug is the labetalol, which is a alpha and beta blocker, which is given as 100 milligram maximum. Remember, all this can be questioned. What is the maximum dose of labetalol? Oral labetalol that can be given, that is 2400 milligram per day. Either you can give us an, or start with a BD dose, QID, it can be given even 4 times. That's how it is given. IV infusion, remember, the maximum dose is 220 milligram. This is also a very important question. What are the contraindications? See, when you talk about a drug, it is very important to understand what are the contraindications. Only then you give a drug. Very important contraindication is asthma. What are the side effects? See, labetalol is both alpha beta blocker, so they have, see, most of these antihypertensives have the side effect of headache. So side effect is headache and tremors. Next is the hydralazine. See, the first drug that is used is labetalol. See, that is easily available. It's kind of cheaper compared to hydralazine. And it's also used in all the government hospitals. So it is labetalol will be the drug of choice in India. When I say foreign countries, if you're giving a foreign exams like PLAB and other exams, remember the first drug of choice will be hydralazine. So hydralazine is little costlier drug which is not easily available in India, and it has a lot of monitoring required for that. Same like labetalol, but it is little costlier, which is not very feasible with the Indian scenario. What is the mechanism of action? It is a peripheral vasodilator. You give it as a oral form, 100 milligram in 4 divided doses. In IV, 5 to 10, and maximum you can give is 20 milligram per day. Remember, it causes sodium retention, need for diuretics. And what are the other side effects? It can cause hypertension. As I told, almost all the things have hypertension. And which is a very troublesome side effect of this is nothing but the tachycardia, tremors, palpitation, arrhythmias. In the fetus, it causes neonatal thrombocytopenia. That is a very important thing. Remember, this can be a question. What are the other things? Nifedipine, as we know, it's a calcium channel blocker, which is given as 5 to 10 milligram TID dose and maximum up to 6 to 120 milligram. Remember, it should not be used with the magnesium sulfate. Why? Because nifedipine is also a calcium channel blocker. Magnesium sulfate also blocks the calcium channels. So it should not be given simultaneously. What are the side effects? Again, start with hypotension, headache, tachycardia. Remember, the headache that in case of nifedipine is very excruciating pain. The patient may ask to stop the drug. So this you should not forget. Almost all the drugs have this hypotension, but very most important in case of nifedipine will be headache. Methyl dopa. Previously, this was a drug of choice in case of a chronic hypertension. Now, remember, it is only labetalol is a drug of choice everywhere. It's a central sympatholytic, and remember, it has an increased risk of postpartum depression. And one such thing that has led to its disuse or stop using one is the fetal intestinal ileus formation. So that is one thing that has led to the its decreased usage. Which is a drug of choice for preeclampsia? It is the labetalol. Any antihypertensive that is contraindicated. Remember, there are so many antihypertensives, but what are the not given in pregnancy is a very important question. It's repeatedly asked, direct question. AC inhibitors, beta blockers, angiotensin receptor blockers, diuretics you are not giving. But remember, where do you give diuretics in pregnancy? Preeclampsia we are not giving, but you give diuretics in pregnancy. Where do you give diuretics in pregnancy? Anybody? Remember, in case of a pulmonary edema, you give diuretics, whereas it is not used as an antihypertensive. Yeah, Arun, you're right. It's pulmonary edema. diazoxide, that is also it is contraindicated. Remember, this is a very direct, straightforward question. What is the mean arterial pressure? How do you measure it? Systolic pressure plus diastolic into 2 divided by 3. It's a very direct question. As I told, during dipstick method, our importance will be 1 plus. But they might ask for what is the trace? It is 0.1. When I say 2 plus, it is 1 gram, and 3, it is 3. Remember that. So, must know, please answer these questions. What is the hallmark of PIH or pregnancy-induced hypertension? I have already mentioned what is the hallmark. Hemoconcentration. Hemoconcentration is the hallmark of PIH, which is the most common hematological finding that you see in a preeclampsia. Remember, it is thrombocytopenia. Please answer this question. Which is a hallmark renal lesion is preeclampsia? I want everybody to answer this question. Which is a hallmark for the renal lesion in preeclampsia? Anybody? Yes, it is glomerular endotheliosis. I'm very happy many people answered. It is glomerular endotheliosis will be your answer. Please don't forget this. Most common visual disturbance in preeclampsia, it is scotoma. We'll come to this later. Prashna's retinopathy, where there is ischemia of the retina. That which is called the Prashna's retinopathy. Amaurosis, which is called the occipital blindness. But here it is because of the occipital cerebral edema. Okay, kindly answer this. Antihypertensive of choice in hypertension. What is your answer? Remember, it is labetalol, not methyl dopa. So answer will be labetalol, followed by that. If you don't have labetalol, the next option will be methyl dopa. What is hypertensive of choice is preeclampsia or pregnancy-induced hypertension? Again, this will be labetalol, followed by that will be hydralazine. If that option is not available, next option will be hydralazine. What is a hypertensive of choice in hypertensive crisis? Remember, it is IV labetalol that will remain as the choice of drug. What is the next we will see what is the target BP. So we have started a antihypertensive. Now you have to know what is your target. You can't be lowering her BP very much. See, high BP is tolerable, whereas very low BP, which causes sudden fall or sudden decrease to the blood flow to the baby, leading to severe hypoxia, and it is very difficult to reverse it back. So it is important you fix a target and you alter the dose according to it. Remember, in case of preeclampsia, systolic blood pressure should be kept between 130 and 140. Diastolic blood pressure should be between 80 to 90. With the chronic hypertension, remember it is 140 to 150, and diastolic blood pressure is 90 to 100. Don't ever try to decrease. Suddenly don't drastically decrease the they should never go into hypertension. Now coming to a clinical scenario, remember there was a patient who came to us with a high BP recording. We started her on antihypertensives. Her BP is controlled. Her fetal well-being is good. The growth of the baby is good. All the baseline investigations are normal. There are no signs and symptoms of any severe preeclampsia. So this is a non-severe type of preeclampsia. That's what the history suggests. Non-severe type. See, when I say non-severe preeclampsia, the BP is well controlled. Baby and mother both are doing fine. When do you deliver them? When I say non-severe, when do you deliver them? It's a very important question. It's a direct question. When do you deliver them? Anybody? When do you deliver the patient? Answer is 37 weeks. Remember, this is the newest guideline that is there. 37 weeks should be your precise answer. See, when I say BP is controlled, see, when I say she's non-severe preeclampsia, her BP